So welcome back to the second of the anatomy videos on the hip and the thigh. We looked at the osteology and a little bit of the neurology in the last video. And today's video we're going to look into the muscles. We'll also look at the nerves and the blood supply again, but this time only in context of their tracks in relation to the layout of the muscles, if you like. Once again, we'll be using Complete Anatomy by 3D for Medical. This is a great resource that you all have access to as students. Please activate it if you haven't already, and you can follow along and learn your anatomy in a more creative way. That said, there are different ways of learning anatomy, and we could approach this area of the body either from a constructive perspective. Maybe we could start with the nerves and then we could look at the regions they innervated and build up from there. Or we could look at this in a more functional perspective, taking the muscles and dropping it back to their constituent actions. Today we're going to look at the muscles first, and in a future video we may well look at the nerves and build it up in a different way. All of this really means that there are different ways you can learn anatomy, and I think it's down to you individually to identify your favoured learning style. As lecturers and as a team, we'll assist you in any way we can. If we can reconstruct what you're learning in a way that makes sense to you, that's fantastic. But I think, at this stage in your university careers, a lot of responsibility falls on your shoulders to identify your favoured learning style. That said, let's jump right in and start looking at the muscles of the thigh. So here we are back in Complete Anatomy, and this view is one we left when we finished looking at the osteology of the pelvis, hip and thigh. You'll see that I've left the ligamentous tissue there, just to remind you that a lot of the support for this area of the body actually comes from the ligaments. And also to just look again, if I can spin this on its axis, add a couple of these connective tissues down at the bottom. We've got specifically the sacrospinous ligament and the sacrotuberous ligament. Now these ligaments provide sort of artificial foramen for muscles to come through, and we'll see that a little bit more detail as we look at the external rotators. So let us spin round and add some muscles in. Just like the shoulder, we can group these into areas. On this occasion, we're going to go from deep and build out, rather than look at particular movements. Let's start by looking at the iliacus muscle. Iliacus originates on the anterior surface of the ilium, and you can see inserts down at the lesser trochanter. It's joined by its buddy, which is the psoas major, and often these are grouped together as the iliopsoas group. Their actions together are trunk flexion and hip flexion. Now quite clearly it depends on your position. If you're standing and you lean forward, it's trunk flexion. If you're lying down or you're standing and you're raising your knee, then it'll be hip flexion. Deeper down is the pectineus muscle, which again is another hip flexor, and also a slight adductor, adductor of the hip when the hip is out to the side. So muscles involved in external rotation. Quadratus femoris. Now this muscle is often confused with the quadratus or the quadriceps group. Quadratus femoris is a very small muscle, and it's an external or lateral rotator of the hip. Joined in this by obturator internus, and this is a really unusual muscle because it's coming from the inside of the pelvis. If I rotate this, covering that obturator foramen and attaching to the rami of the pubis and the ischium, and it sort of has a long tendon that comes around the corner and grabs hold of that sort of medial surface of the greater trochanter. We can add in here a series of muscles called the gemelli, or the Gimelis muscles, and here you can see where they sort of very small thin muscles that join in, but they're also joined by piriformis muscle, which is a significant interest to therapists, particularly because of its relationship with the sciatic nerve. In some people, the sciatic nerve sort of deviates and splits, and part of it travels through the piriformis. What this ends up doing is causing a little bit of sciatic pain, and quite often a lot of sciatic pain, in people where the piriformis is maybe overactive or hypertonic. I'm zooming out there so you can see this muscle here. This is gluteus medius, and the most superficial of the two gluteal muscles that are involved in this area of the pelvis. There is gluteus minimus, and this is involved in internal rotation and medial rotation, along with its partner, a superficial partner, gluteus medius. So they're contributing to an opposite action. They're actually internally rotating the hip. You will be familiar with the largest of the gluteal muscles, which is gluteus maximus. Gluteus maximus is the largest muscle in the body in terms of its general bulk, and originating on the sort of iliac crest, sacrum and coccyx, it blends in with the iliotibial tract, or the ITB band, along with tensor fasciae latae muscle. Its main role is to extend the hip. It's a very strong hip extensor and works in along the tract with tensor fasciae latae, which is mainly an abductor. We'll move around to the front. You remember that a few minutes ago we spoke about the psoas major and the iliacus, the iliopsoas group. They're joined in hip flexion by the rectus femoris muscle. Rectus femoris is a biarticular muscle that crosses both the hip and the knee joint, so it has action in both areas. It's reasonably active as a hip flexor, but is a little bit more active when the knee's already extended. What you'll see functionally in people is that the rectus femoris has to take up its slack in order to be an effective hip extensor. And quite often when we talk about dysfunction of the core stability muscles, one of the sort of key indicators is the muscles not engaging before rectus femoris has actually become active. And when that happens, we end up finding that the global mobilizers of the area take over in terms of stability, and this can lead to fatigue and then injury. Ideally, all core muscles will be active before rectus femoris is pulled into action, in other words, while it takes up its slack. And if you sort of look at your own leg and put your hand on your leg and put your hand on your rectus femoris, which is the most superficial anterior muscle, and then go to hip flex, you'll feel that rectus femoris fire. You've got less than a second. It's measurable in half a second for everything else to fire up around it. And it's something that certainly as rehabilitators we focus on a lot. Understanding those relationships between muscles can be quite important. Once we leave the area, we've got a muscle in between which sort of has a role in flexion and medial rotation as well. This is Sartorius muscle. This is the longest muscle in the body, and maybe it's worth just zooming out a little bit so you can see its full extent. You can see by its sort of position, its origin on the ASIS, as opposed to the rectus femoris, which is on the AIIS. It is a long muscle and it travels medially and across the front of the thigh. It's actually quite difficult to palpate until you combine its actions together. And if you want to test Sartorius in isolation, you've really got to focus on all of its action. So it flexes and medially rotates the leg at the knee joint. It assists in flexion, abduction, and lateral rotation of the thigh at the hip joint. So it's a busy little muscle, and probably one of the most functional images you can think of is if you use the sort of the inside of your foot to kick a football off the ground. That action of external rotation, knee flexion and hip flexion would be Sartorius in action. Let's move in again a little bit closer, and we can now see the adductors. So I'm just going to take a layer of muscle off here so we can focus on these a little bit more. We spoke about pectineus earlier, which is a hip flexor and an adductor in a certain position. As we move round, we've got adductor longus, and we've got Adductor magnus, and tucked away at the very back we've got Adductor brevis. These three adductors, adductors, are involved in sweeping the leg across the body or bringing the leg back into neutral from abduction. They're assisted by gracilis muscle, which also has a role in flexion and medial rotation at the knee joint. So this is again a muscle that crosses two joints. If we look now at the vastus group, they're here on the thigh, and we are covering the thigh, but they're really knee extensors. So we'll look again into them a little bit more detail next week. But we have the other three of the quadriceps muscle group here, rectus femoris being the first. We've got vastus intermedius, vastus lateralis, and vastus medialis. And you can see the oblique attachment of medialis there as the fibres move around. As I said in the last video, lateralis and medialis, so lateralis there, medialis there, actually originate from the linea aspera on the back of the femur. And you can see there that vastus intermedius is originating on the anterior surface of the femur. All of these muscles, including the rectus femoris, come together to form a common quadriceps tendon and then engulf the patella and insert the tibial tuberosity. Moving around onto the posterior view, we can now see in more detail the hamstring group. The hamstrings themselves, again, are bi-articular, so they cross both the hip and the knee joint. On the lateral surface, we have the long head of biceps femoris. On the medial side, we have the semitendinosus and semimembranosus. These muscles are involved in hip extension as well as knee flexion. And again, we'll cover them next week when we move down to the knee. Just deep to the long head of biceps femoris is the short head of biceps femoris. So you could say, in fact, that the hamstring group are very much like the quadriceps group and that there are four muscles. We'll complete this section of the video by looking at the vascular system in a little bit more detail. Just to remind you that the femoral artery travels underneath that inguinal ligament and into that femoral triangle. It's joined by the femoral vein and also the femoral nerve, which is a deep nerve, innervating largely this area at the front. The obturator nerve innervates mainly the adductors, the femoral nerve mainly the hip flexors and knee extensors. And if we swing around to the back, you can see there's a very large nerve at the back, which is the sciatic nerve, which, having originated from its plexus and deviating in some people, is innervating the hamstrings. Back at the anterior view now, and if we layer up the muscles in their entirety, you'll see that even when a full complement of muscles are added to the hip, the pelvis, and the lower limb, we've got a lot of superficial nerves and superficial blood vessels. Be aware of these in your studies. Make sure that you are fundamentally aware of where the major branches are of both the blood vessels and the nerves. They become areas of special consideration for all sorts of medical professionals. And also make sure that you approach the learning of these muscles in a way that suits you. I mentioned it before, and it's becoming increasingly important at this point in the course, where we're moving into more formative assessments, that you take the time to identify your best learning style and either take a constructive or deconstructive approach or a combined approach to your learning. Next video, we're going to look at the knee in a little bit more detail, and then we'll move on to the leg, the foot and the ankle.